Welcome, everybody. Thank you for joining Adapt NCLEX. Today, we're just going to spend some few time and learn how to approach acute GI NCLEX questions. So how do you approach it? I told you, buzzwords, right? After the buzzwords, look for location. Location is key for every GI pathology. They're going to tell you where the thing is located. And they're going to give you signs and symptoms. And those are the buzzwords you pay attention to. Then you should also pay attention to referred pain for these particular problems. Sometimes some of these pain get referred to another place. Okay, so just those are the things you pay attention to. Like if they give it to you, watch for the buzzwords, the location of the pathology, and whether the pain is being referred somewhere. So let me show you what the abdomen looks like. This is your stomach, right? And you have your small bowel coming like that, and then you go here. So this is the usual way. So this is your small bowel. You go into the appendix, and you go into the cecum. So this is the colon, and then he's made his way here to transverse colon into the spleen, neck fracture, then the sigmoid coming, and then your rectum coming like that. This is a simple way. There's different organs, okay? Your liver sits here like that. And he has gallbladder here. Okay, and then your pancreas sits right here, right in the middle, just behind the stomach. Your spleen is a little bit bloody, so it's over here. Okay, it's attached to the transverse colon. So this is your spleen. And this is the sigmoid. So this is the sigmoid. And your appendix sit here like that. And this is the liver. And your gallbladder. Like I told you, location is your key. You're looking for location. Your belly button sit here like that, right in the middle. And your kidney, I'll put them here. They are behind, so the back side. So I'll put one kidney here. There's two. One is just behind the spleen. So these are your kidneys. This is all you need to know. You don't have to draw it. If you want to draw, I'll draw a box. But you can draw a box and put them there and say, this is where all this pathology is. If I have an acute problem with any of them, you will be able to figure out what is the problem, right? So picture this in your head. I want you to picture it. You can draw it in the box form. You draw it in the box form like that and divide the abdomen into 4 quadrants. And you put the appendix here, the sigmoid here, the spleen here, the liver here. So the liver here, appendix here, the diverticulum, or that in the sigmoid, basically, the spleen here. And you can put the pancreas right here like that. And when they ask you a question, and this is your umbilicus, when they ask you a question, you just look at the place and then you figure it out. By labeling this right upper quadrant, this is right lower quadrant, this is the left lower quadrant, this is the left upper quadrant, and this become mid-epigastrium. That's where the pancreas is located. So you have to figure out where this problem is. So pay attention to where the location of each problem is, and you will be able to answer any questions on the pathology. So that's the first thing. Now, your GI tract is your best defense, okay? Best defense, think about it. So when you're getting sick, your GI tract will alert you. It alerts you that something is going wrong. How does it do that? You became nauseated. You have some nausea. You can have GI upset. Classic signs. It's telling you something is wrong. And that is the beginning of that. And when the patient becomes nauseated and is upset, what does he do? Patient make themselves MPO. They don't want to eat anymore. Classic. Something bad is happening. The body does not like it. Therefore, they make themselves MPO. So if they come into the hospital, we don't have to go details in the pathophysiology. If they come into the hospital, they are in the hospital. Anybody with a GI pathology, there's few things you can do because it's an acute problem. There's few things you can do that will save their life. What as the patient does already, they already make themselves MPO. Every GI pathology, keep them MPO. In the case form, whatever, nothing, no sips of clear. It's a trap, regular diet. Give them ice chip. When you see it in the case, they come in with the GI pathology. Don't fall for it. Never pick that answer. That answer, absolutely wrong because it's a GI pathology. The patient himself made themselves what? MPO. Nothing by mouth. So you should not put anything in their mouth. Most GI pathology is an inflammatory process. Inflammatory. So let me use the appendix. This is the appendix. It's blocked by some stone. And so he's going to have inflammation around it. Inflammation is painful. That is your body telling you something bad is happening. Inflammation is a form of your alert. It's an innate problem for you to adjust so that we don't get injured. You touch something, there will be inflammation. It's going to be painful. Pain stimuli will start firing and you run away from it. So inflammation is painful. And most GI pathology has some form of inflammation. Therefore, what? They're going to have pain, right? So manage their pain. So pain management. They need some pain management. So don't forget to give them pain management, right? If I'm MPO, I'm not eating, you got to help me out. Otherwise, I get dehydrated, right? So they get an IV fluid. You see where it's coming from. Don't memorize it. Nothing like formula telling you this. You have to know that this is what is expected. Yeah, you don't have to memorize it. His patient is MPO. It's no brainer. You got to help them. They're sick. Give them fluid. They have inflammation. There's going to be pain. Give them pain medication. If you have inflammation, okay, they're going to have some fever. That's your body reacting, telling you there's fever going on. So I expect this patient to have some fever. So this is the treatment before we go to the expectation. So if there is inflammation, most of the time, antibiotic is your best bet. So they will need some form of medication. So antibiotic is some of the part of your plan of care, right? These are classic, okay, classic. There is some pathology problem that will make them vomit, okay, will make them vomit because of the inflammation. Inflammation in your GI tract slows things down. That's the reason why they vomit. The bowel does not like inflammation. So when it's infection there, it slows it down. So they develop ileus and they can vomit. They have partial form of obstruction, but not true obstruction. Everything slowed down. Because of that, some people may need NG tube, but not all of them. Okay. Since they are not eating, sometimes you develop gastritis, inflammation in your stomach, and you can develop ulcer. So we want to protect the stomach. with the stress, all the stress that is going on, we want to protect the stomach. What do you give to protect the stomach when they're stressed? You give them PPI, proton pump inhibitor, right? PPI. So this is what you do, right? If they're bleeding, it's no brainer, right? They will get some blood. And there's some specific problem that they need specific medication. So depending on the situation, they may need some specific medication. So that's the key. So these are your friends. Every time they give you a case form, look for this and see what you do for that patient. At least 4 of this, you have to do it most of the time. You got to make them MP. You got to give them pain medication. You got to give them IV fluid and antibiotic. These 4, you should not forget it. They are common. And then depending on the situation, you get an NG tube or you get a PPI or blood. Some people say just put a PPI, that's fine. NPO, pain management, IV fluid, antibiotic, and PPI. Depend if it's part of the choice, but not everybody needs PPI. But that's the key aspect of it. Now, that is the basis of the management. Okay, this is what I want. I don't want you to forget that. If you keep this, the case study will be easy. Any case study you get is going to be easy. So that's your key. This is your management. Now, let's go to the things they do for you, try to trap you when they do prioritization. This is what happened. I drew the team for you, and I divide this, okay, and I told you the appendix live here, like that. If you come in and you have appendicitis, look at what I'm going to do. An itis, inflammation. Expect this patient to have fever. Don't worry about it. So temperature high. That means he has fever. Itis, inflammation. Your white count is going to go high. They are mad. They're trying to save your life. WBC is high. The normal does not matter. It can give you 50 million. It's an itis. What are you going to do about it? You got to fix other problem, but it's an itis. Whatever normal they give you, take it with a grain of salt, right? They're going to have pain. This is the problem. This pain for appendicitis is on the right lower quadrant. If they come in early and you ask them, what is your pain like? It will say, it starts from here. So if you get a case and they said peri-umbilical and now is on the right lower quadrant, that is classic appendicitis. That's all. And then they ask you, what do you do? We already talked about it, but this is what they will give you. The only time you worry about appendicitis, not because they have fever, not because they have white count, not because they have right lower quadrant pain, is where they have no more pain. And this is your B-sharp moment, I call it. The reason why the appendix is under pressure. It want to open up. It get dilated, and the pressure is what gives them the pain. Initially, the pain is non-specific. It's a visceral kind of pain. Then it localizes into the right lower quadrant. That's why I start from here and come down here. This is your right, this is your left, and this is the right lower quadrant. When they have no pain, that pressure filling structure is ruptured and they pass out. So they have developed abscess, perforated appendicitis, and they have no pain. And that is the B-sharp moment. That one, you have to see them. Another trap. If they tell you appendicitis and they tell you they have board-like abdomen. Yes, you have to see. This is the sign of peritonitis. That is a sign that they've perforated. They will perforate and they will develop peritonitis. In addition, if they can perforate and develop peritonitis. They can perforate and they will not have pain because of the pressure. When the sepsis is too much, you can develop peritonitis. So you're looking for pathways, but like what? Abdomen, that's peritonitis. That patient, you have to see them. It's a peritonitis. So that's the key, okay? That's the key words for that. So that's the problem for this. And those are the things you pay attention to. You don't worry about anything. What do you do with this patient? He's MPO. He has IV fluid because he's MPO. He has an itis. He has an antibiotic. He can get a PPI. If he has nausea, if he has no nausea, there's no need to give them Zofran. I mean, thing you have to think, guys, if they give you a case, the patient has no nausea, okay, there's no need to knee-jerk reaction. You get the Zofran or Dancitron. So antiemetic, yeah, if they have signs of they telling you they're nauseated, of course, yes. But it's not all the time. This patient does not need NG tube. He does not need blood. Most of the time, they go to surgery 24 to 48 hours. And the surgery is laparoscopic appendectomy. This is done laparoscopically, so lap appendectomy. Small incisions. They can go home same day or 24 hours. And they can take shower, but no bath for 6 weeks. They can resume activity slowly. And they can eat whatever they want to eat. That's all. Your B-sharp movement when they have peritonitis or they have no pain. That's appendicitis for you. So that one is taken care of. Now, let's move to the right lower. The right lower is where this sigmoid is located. This is where your sigmoid is located. You have diverticulum. Diverticulums are packets of the colon. If this is the colon, you have these packets that develop due to pressure because we don't have what? No IV. We don't drink a lot of fluid. So lack of fluid, we lack fiber, and we strain too much. And no exercise. So this is the risk factor for that. Guess what? Location, 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 once again. If they have inflammation, where do you think it's going to be? Left lower quadrant, pain. Don't see them. They have inflammation, white count elevated. It's fine. They have inflammation, they're going to have fever. It can be 1010, whatever it is, 104, 103, it's fine. We give them antibiotic, okay? They may have nausea, yeah. If they have nausea, yeah, they may need antiemetic. These patients don't need NG tube most of the time. They don't need, they're not distended. They have no, they don't vomit. Most of the time they have nausea because they make themselves MP already. What you give them? Same thing, right? You give them pain medication. You give them antibiotic. This is specific. This patient will need metronidazole and then ciprofloxacin. Most of the time, that's what we use. Okay, if they're allergic, you give them something better, right? But you need to cover gram-negative and anaerobes, right? And this is the trap, okay? Of course, they need an IV fluid, and they need to be MPO. These patients, they will trap you, okay? The traps are what? Give them laxative, which is like probably Miralax, negative. Give them enema, negative. Do colonoscopy. I call it negative. Do flexible sigmoidoscopy. Negative. Why? Anything you put from the bottom is going to perforate them. So nothing go into the rectum. That is the key. Nothing go into the rectum and don't stimulate them because they will trap you with that. These are your traps. So, and this is your intervention. If I tell you somebody have diverticulitis and he's getting colonoscopy, you the next need to intervene. He's getting enema, you have to intervene. He's getting flexible sigmoidoscopy, you have to intervene. This is what the patient needs. They don't need surgery. These people, we make them MPO, they get better. We start with clear liquid diet, advance their diet slowly, and they go home. You teach them, now we want to prevent anhydrous formation. Even though you have diverticulum, we don't want anhydrous anymore. We cannot prevent or stop the diverticulum that was already there. We can remove them. We will prevent them from becoming anhydrous infection. So some fiber, okay, some water, 2 to 3 liters of water a day, and do some exercise. Exercise does not have to be go to the gym and lift 400 pounds. Moderate exercise, which is what? 30 minutes a walk. 30 a walk. That is moderate. This is science, okay? 30 minutes walk 3 times a week. When they give it to you, this is what you're looking for. You walk in 30 minutes. You don't have to do it like 100 hours, 30 minutes a walk 3 times a week. If they're doing 7 days, excellent. They're doing fine. Location, and what you expect. All that I've said is normal. These are the people you intervene. What is another clue you should intervene? This is an inflammation. It's an inflammatory process. If they perforate, they can perforate. If they perforate, their pain migrate up. So their pain goes up. It goes up here like that. So for diverticulitis, you're looking for pain at left upper quadrant, not left lower quadrant to intervene. This is your priority. And this is your B sharp. That means they've developed an abscess. That is what you want to prevent. Left upper quadrant pain is a B sharp movement. They develop an abscess. This is all you need for the NCLEX. You don't have to think about anything when you hear about this. Prevent diverticulosis and prevent further problem. That's all. Now, let's go to the next one. The next one, I draw it, I show where the liver is the gallbladder, it's here. This is the gallbladder. The gallbladder is a vestigial structure. You don't need it, it's a storage, it's under the liver. All it does is store bile, okay? And sometimes the bile, when we eat too much fatty food, okay? So fatty food. And sometimes if you're a female and you're more than 40 or 45, and then you're a little bit overweight, okay? This is the problem. And you have a lot of babies, you have too much cholesterol floating around, right? And that is what causes the problem. It causes the problem. And they form what? Stone. They form stone, and these stone block the gallbladder and it causes inflammation. That's all. That is the problem. So, and it's located in what? Right upper quadrant pain. That is what? Cholecystectomy. This problem make you make stone. I call it cholelithiasis. So this is the risk factor for cholelithiasis. It's stone, making stone basically. You just making stone formation. So this is the risk factor to form stone. When you get stone block the tube, the gallbladder, you form anheitis. We already know anheitis, you're going to have fever. Anheitis, when you come in, your white count will be high. Anheitis, when you come in, you're going to have pain. If you have fever, I give you antibiotic to take care of the white count. The pain, I give you pain medication, right? I will make you MPO. When I make you MPO, you get an IV fluid. If you're nauseated, you get on dancing throne. If you have nausea, most of the time they don't vomit. Some people will vomit a little bit at home, but most of the time they feel nauseated, so you make them MPO. They don't need blood, nothing like, bleeding. What do you need to do? These patients, usually they will have surgery, but they can have surgery 24 to 48 hours. Sometimes 72 hours, okay? You can put them on antibiotic and then they have surgery. The surgery is laparoscopy, cholecystectomy. When they give you this kind of scientific word, don't worry about it. Chole, that's the gallbladder. Cyste means you're taking something away, okay? And otomy is coming out. So we're removing the gallbladder. Post-op management, they have small incision. If this is their belly button, abdomen, they will have, if this is their abdomen and belly button, they have incision, small incision here, one here, one here, and one here. Okay? These are all like a 1 centimeter incision. And there's nothing, there's dermabond on it, basically a glue on top of it. They can take shower, but no bath. So no bath for like 6 weeks. They can start the activity slowly. They can eat, but we want them to be on low-fat diet. That's all. This pain, when you have it, where do you think it goes? To the right shoulder. So when they have pain, you go into the right shoulder or the scapula. So when they tell you somebody with the right upper quadrant pain, go to the scapula or the right shoulder, is cholecystitis, inflammation of the gallbladder. What about endoscopic laparoscopy? Bad combination. There's nothing like endoscopic laparoscopy. Laparoscopy, you look inside. Endoscopy, look into the tube. There's nothing like laparoscopic endoscopy. So they don't do that. They do laparoscopic cholecystectomy. Endoscopy, look into a tube. Laparoscopy, look outside. You can look outside and look inside the same. So that's the difference. So you don't do that. So right upper quadrant radiating to the right shoulder is a classic signs and symptoms of cholecystitis. They will present with what? Fever, white count, and they will have pain. That's all. So that's that one. Now, let's look at the other structures that we drew. I show you the pancreas is in the middle. So the pancreas is behind the stomach. It sits here. Location, pancreas. So where will your pain be? Mid-epigastric, right? They will have nausea because of what? That's the only people you worry about. The stomach sit here and it's behind here like that. So when there is inflammation, it affects the stomach. These are the people, they will have nausea, they may vomit. They will be distended. Therefore, you know what to expect, right? They have pain. They may have fever, right? All these things and the pain. So they will need NG tube if they're vomiting or if they distended. Of course, they will need PPI. They will need IV fluid. These people, IV fluid is a lot of IV fluid. They will need pain management. They don't need antibiotic. Okay, if somebody tell you that, that's not true. Pancreatitis does not need antibiotic unless it's infected. They don't need antibiotic. They will need antiemetic if they're vomiting. Yeah, sure. But those are the classic things they usually, we put them on. Don't worry. They're going to give you this amylase, right? They'll give you a bunch of it. They will say, another 15,000. Don't worry about it. Lipase, they will give you 50,000. Don't worry about it. No matter the number, don't worry. The pancreas is a fatty tissue, okay? It's a fatty tissue. Pancreas is a fatty tissue, and it sits here like that, wherever it sits. And when it gets inflamed, the enzymes that is secret comes out. And so you should expect the enzymes level to go up. Amylase, no matter the number, don't worry about it. The lipase, no, just let it be. The only time you worry about a pancreatitis, once again, the only time is few. These people, pancreatitis, if you understand the pathophysiology, is a burn, okay? And so you got to pour water on it. The pancreas will be crying, singing, pour water on me so that I can cool down, cool me down. That's what the pancreas will be saying. So you pour water on the pancreas. So they will require a lot of fluid. Because of that, this is what happened. The pancreas, like I told you, it sits here. They will require a lot of fluid. The diaphragm sits here like that. They get distended, and it go to the lung, and it can develop acute respiratory distress syndrome. So one of the B-sharp moment is when they have airway issue. So pancreatitis patient with the shortness of breath, see this guy. Don't worry about pancreatitis patient with lipase of 1 million. Don't worry about it. Don't worry about them with abdominal pain. Don't worry about them with nausea or vomit. Don't worry about it. Let it be. Lipase of 1 million. Don't worry about it. The other thing too is the spleen sits here like that. And the blood vessel from the spleen, it just runs behind the pancreas. Like that. This is the problem. This is what people talk about. This is so I'll put the green, even though it's not green. Blood, this is the blood vessel. I guess green is not good. So this is right here like that. When the pancreas is inflamed, the blood vessel get inflamed. And what happens? It can rupture. When it rupture, it has 3 directions. So pancreatitis with bruising around the belly button is your friend. Bruising here is your friend. Flank. Bruising here. These are what we call B-sharp movement. That is what your body like. If you don't understand the pathophysiology today, I'll show you why people always talk about it. So pancreatitis with periumbilical ecchymosis, yes. So those are your B-sharp movements. So periumbilical ecchymosis and flank ecchymosis are your friend. Those patients are bleeding. They're bleeding and you have to see them. This is what we call Kellen signs, and this is what we call gray Tanner sign. These two guys, they're bleeding. Plus this guy is what? Is having airway issue. So when you see a question with the pancreatitis, if none of this was given to you, please don't worry. If they say, who do you see? And they don't tell you that he has shortness of breath or something like that, yeah, that's let it go. If they don't tell you that he has frank ecchymosis or something like that, it's not a B-sharp moment. It's an expected finding. These findings is not expected because now the pancreas inflammation has penetrated into the vessel and the individual is bleeding. And therefore, if he's bleeding, it's hemorrhage. When you're hemorrhaging, it becomes a B-sharp. And B-sharp is what? If you never heard about it before, this is breathing. Breathing problem, not just breathing, but look at things that can kill you. What is that? Pneumothorax, right? Pain, bloody sputum. That's what. Pulmonary edema. What? Flared chest. I'm clinical. That's why you hear me saying that I don't do book. Flared chest, because I take care of patients and I know what they look like, not what the book says. You know, this is clinical. Somebody with the flared chest is having airway and breathing issue. Electrolyte, you're looking for potassium, magnesium, calcium, sodium. These are things that will keep your body in homeostasis. If they screwed up, you screwed. The normal has to go up or low. Still, it's bad. The S, you're looking for shock. They're not going to tell you the patient is in shock. They'll give you signs of shock. What is that? Diaphoretic, hypotension, okay, dizziness, tachycardia, what? Tachypnea, hypotension, yes. And sepsis, if I give you somebody with the temperature of 103, that's not sepsis. You have to have more. So no, that's why you don't follow just temperature. Look at the situation. Appendicitis with the temperature of 103 is not sepsis. Okay, somebody tell you that it's not sepsis. Sepsis is a collection of things. You got to put all together. The examiner will not just give you temperature and you think you're septic. Unless the patient is immunocompromised, yeah, that temperature is bad on them. But appendicitis, that temperature is okay. That's why I said, don't memorize it. Think about the pathophysiology and put it together. Okay, I digress, sorry. But this is the B-sharp, and then the airway, of course, airway. You know, airway, like fat embolism, pulmonary embolism. Those are the things you worry about. Not somebody just with shortness of breath. When I hear pulmonary embolism, I know I have a problem. So those are the key. So these patients, they're bleeding, and you have to worry about them. That is the patient you see for pancreatitis, no any other patient. Okay. Now, your stomach can also get into trouble. People don't talk about it. Okay. The stomach and the duo, the small bowel, duodenum, and this is the gastric. You can have ulcers, and these can what? Perforate. When they perforate, you have a problem. They will present like peritonitis. They will have what? Board-like abdomen, right? They will have fever. Okay, they will have pain. These three things, when you hear it in the patient, and it's going to be sudden. He said, hey, they present a case to you, sudden onset of board-like abdomen with the fever and pain. Is perforation. There is a viscous, hollow viscous perforation. The board-like abdomen is peritonitis, therefore, hollow viscous problem, oral viscous problem. Somebody is asking, what is the H in the B-sharp? The H is hypothermia, okay, and hypoglycemia. I'm not pay attention. If your temperature is 96 and somebody's temperature is 103, this guy is deadly compared to this. This guy can go into arrhythmia. So hypothermia is more dangerous than hypothermia. So that's why high temperature is not part of the B-sharp. Low temperature is bad. They can go into arrhythmia and they can die. Same thing, hypoglycemia, sugar of 200. I don't care about you. I care about somebody's sugar with 45. Finger stick of 45 is dangerous than finger stick of 200. So that's the way you go about it. Okay, so perforation, they have blood-like abdomen, fever, pain, and is going to be sudden onset. This patient needs surgery. The same thing, the same treatment, but pay attention. The way you see I presented, they will be MPO. They will need IV fluid. They will need antibiotic. Okay. They will need some pain management. But this patient is going to surgery right away. Is sick. Okay. His white count, the VBC is going to be elevated. Don't worry about it. So these are the features you're looking to make your differential diagnosis. Differential diagnosis. Therefore, how do you tackle this acute GI problem? Location and the bus width. All you care about is location and the bus width. And when you do that, you see that it's not that hard at all. The only person who needs blood, okay, if somebody is upper GI bleed, that means they're bleeding from the mouth or from the bottom, so rectum. So they have upper GI bleed or lower GI bleed. And when they give you that question, say somebody came into the emergency room with hematemesis, basically vomiting or GI bleed, this one changes, everything changes right away. So everything changes. It becomes what? Emergency. Because they're bleeding. And therefore you do your ABC as usual. You know, I don't like it, but I want to say it. It's airway breathing issue. When they present the case with somebody with upper GI bleed and lower GI bleed is bleeding, especially the upper GI, your number one, okay, number one is airway. If they're vomiting, put them on the left side, left lateral. It's number one. Before you do anything, don't choose any answer choice. They're vomiting. If you don't do that, they will aspirate. Put them on their left side. Then check their breathing. If it's okay, you give them IV fluid, right? And then you type and cross them because they're going to get blood. When someone is bleeding, give them blood rather than crystalloid. If you bleed, I give you blood. Don't give me water. I need some blood. And then the rest, I mean, they will need endoscopy, EGD, but you are not involved, so you call somebody. Because they're bleeding, they will need PPI. These people need exactly PPI. And we have to decrease secretion of the GI tract. If they give you a question and you don't know this is the medication used, or creotide. This would decrease the secretion and that will stop the bleeding. And then they will need a beta blocker. You also decrease secretion, planktonic circulation in the GI tract. Most of these beta blockers are non-selective, so like propranolol to help with the bleeding. That's the management of somebody with the upper GI bleed. So if I give you a question like that, GI bleed, yeah, you expect PPI, right? you expect what? Blood, right? You expect what? And enoxaparin, right? You want to put this patient on enoxaparin, I guess so, right? You expect type and cross. You expect endoscopy, so EGD. This is your classic select or apply, right? You expect what? NG tube, right? Which one you want to choose? I'm bleeding from the upper GI. Do you want to give me PPI? Do you want to give me blood? Do you want to give me enoxaparin? Do you want to give me what? Type and cross and type my cross, take my blood and do type and cross? Do you want to give me EGD? And you want to give me NG tube? Which one would you want to select? Select or apply. Let me see what you guys think. What are you going to do? I'm bleeding, upper GI bleed. Select or apply. Which of this do you want to choose? Let me see, somebody can type the answers. Which of this do you want to choose? PPI, blood, enoxaparin, type and cross, EGD, or NG tube? This is what you expect the board is going to ask you, right? Of course, you get a PPI. Of course, it's going to have blood transfusion. It's not getting this. This is going to make them bleed. It's anticholinergic and anticoagulation. It's going to get a type and cross, right? You most likely look at the source of bleeding, endoscopy. It's not getting NG tube from the nurse. They can place the NG tube while they're doing the endoscopy because it's bleeding. So that is the way you do these kind of questions, and that is the way you approach it. Acute GI pathology, you have to master it. And when you master it, pay attention to the buzzwords. That's all. That's all I want you to pay attention to, because if you do, the rest is history. The rest is history. If you do that, the rest is history. You don't have to worry about anything at all. So that's that. Now, let me give you a question and let me see if you guys can try. We just work through it. I don't have any question. But this is what is going to happen. You have diverticulitis. And I give you the VBC of 24,000. You have appendicitis. And you have fever of 103. You have pancreatitis. And I give you shortness of breath. Okay. You have Cystitis. And I give you pain 9 out of 10. Who do you want to see? Who is your priority? Who do you need to intervene? Which of these patients you want to intervene? I told you the key is focused on the unexpected finding, the B-sharp movement. Which of this is based on definition? Define the thing, break it down, and see whatever they've given you. If I see that in diverticulitis, if I see it every day you come in with diverticulitis, that means it's normal. When you have pneumonia and you're coughing and you come in with pneumonia and you're coughing, do I see you first? No, because I know when you have pneumonia, you're going to cough. So who are you going to see in this patient? You be the judge. So there's no need for us to see a couple of these patients. We expect certain things from them. It's not a problem, right? Your fever, 103, is fine. We'll give you some acetaminophen and we take care of you. Your itis, I expect you to have the VBC, right? Elevated. You have itis, I expect you to have fever. Pancreatitis, I don't expect you to have what? Shortness of breath. It's because we have given you too much fluid. Now you're having respiratory problem. It's unrelated to your pancreatitis. Cholecystectomy, I expect you to have pain. So you should see that guy. You should see that guy. So you have right lower quadrant pain, appendicitis. So right lower quadrant, I tell you, umbilical, then migrate to right lower quadrant, then suddenly no pain. That's your number one. Then left lower quadrant pain. He has fever. His white count is 30,000. Now, left upper quadrant pain. Who do you see? Now, you come in with what? Pancreatitis. Okay, pancreatitis, your amylase is 200,000. And then I say cholecystitis with pod-like abdomen. And then I tell you, somebody coming with this is in the hospital, then sudden onset of mid-epigastric pain, right? Radiating to the back and board-like abdomen. This is all made up. Select or apply. Who do you want to see? 1, 2. It's a select or apply. 5 patients. Who do you want to see? Who do you think is a priority? Like I told you, it's acute GI problem. If you understand it, it's not that hard. You just don't get trapped by anything else anymore. Who do you want to see? You be the judge. Okay. It's a select or apply. So pick those that you're confident. Select or apply. There may be more than one answer choice. So you got to pick those you think is relevant. So, like I told you from the beginning, it's all location and what I don't expect to see, my B-sharp moment. My B-sharp moment, peri-umbilical pain, it migrates to the right lower quadrant and suddenly no, this is what? Then draw your diagram. I started from here. I go to right lower quadrant. Now I don't have pain. What is in the right lower quadrant? Is your appendix. He has appendicitis and no pain. He has developed an abscess. This is patient you should see. Left lower quadrant pain, okay? Fever, white count, what is that? Left lower quadrant pain, fever, white count. This is definition of what? Diverticulitis. All of a sudden, left upper quadrant pain. Oh, we have an abscess. I'm seeing you. Pancreatitis, amylase of 200,000. If you have pancreatitis, I expect your amylase to go up. The normal does not matter. I expect your lipase to be up. The normal does not matter. I expect what? You to have pain. I expect you to have some nausea. I expect you to be distended. I expect you to have mid-epigastric pain. Where does the pain go? To your back. All of them is an expected finding. But when do I don't expect? When I see what? Periumbilical ecchymosis, frank ecchymosis, and you have airway problem, like shortness of breath. Thus, cancel it. Cholecysteitis, right? But I have what? Board-like abdomen. Therefore, peritonitis. Don't leave this patient alone. The buzzword is what? Board-like abdomen. What other word the board-like? If you check my YouTube, click on a video, prioritization, or look at the NCLEX challenge and look at the prioritization. NCLEX challenge and look at prioritization. You will see something they call abdominal rigidity. This is the buzzword, okay? Board-like abdomen. These are all diffused abdominal tenderness. Yes, this is bad. So that's what I'm looking for. Now, number 5, sudden onset, mid-epigastric pain radiating to the back and the board-like abdomen. What is in the mid-epigastric? It can be pancreatitis or your stomach. This sound, if it's going to be pancreatitis, I'll give you some amylase or not, something like that. This look like perforated gastric ulcer. Classic presentation. When they give you, when you see a case and you present like that, the first thing that should come into your mind, is it pancreatitis or gastric ulcer? Mid-epigastric pain, going to the back, and then he has board-like abdomen. The pancreatitis won't do that right away. So your number one answer in your differential diagnosis is the gastric ulcer perforation. The pancreas and the stomach in the same area. But that's a key. And this patient, you have to see them. Therefore, 5, you have to see. So we have 1, 2, 4, and 5 are your right answer. If you have problem, just check Adapt NCLEX and you'll be fine. These are the things I want you to guys start thinking when you're answering these kind of questions. You'll be fine. Just stick with some, you have your own way of answering the question. I'm not saying pick mine, but I'm just telling you there's a way you can attack NCLEX questions, and they're not going to hide them. They have to give it to you in order to make the exams fair. Board exams are designed to be fair. It's not, they don't want to fail anybody. They have to give you words that you can figure it out. That's why some of the questions are what? Tested. They tested multiple times, see what is the frequency of answering it. And if it is very high, they have a benchmark. If they try some of the 15 questions they put in and people are getting 75, 80% of that question, that means it's a legit question and they will put it in the Acute bank. And so they know they have to try this question. Sometimes the question I said, the verbiage may not be right to confuse people. That's why they try question. They are not there to trick you. But if you master your content, you'll be laughing at them in your head. Why do you give me this question? It's straightforward. Your eyes will all open and you'll be able to identify the buzzwords. And it's clinical. That's what we do. We look at the patient, they tell us what they have. We put 1, 2, 3 together and say, oh, you have pneumonia. Oh, you have meningitis. Oh, you have pancreatitis. And that should not be that hard. Okay, guys, before we go, there's one more people always forget that is part of the acute GI problem. That's your kidney. It sits here like that. There's 2 of them. And it goes here into your bladder. Here's the urethra into your bladder. Okay, so this is your bladder. And this is your kidney. Your belly button sits here. This is very good for differential diagnosis. If they tell you somebody have a frank pain, it goes to the belly button. This is what we call pyelonephritis. that is a kidney problem. It's an inflammation of the kidney, infection. Something is wrong. Something is blocking the kidney. Don't get confused. This is completely different. This is like pyelo. The pyelo is the kidney infection. The pyelo is the infection. Okay. And the nephritis is the kidney. So infection of the kidney itself. If they tell you this pain, frank pain, go into the groin. This is the groin. This is kidney stone. I want you to, this kind of nephrology question or renal questions is all radiation of pain and location, as I'm trying to keep on repeating it in your head. Location and radiation. So frank pain, but where does it go? To the groin. Is what? Nephrolithiasis. This is kidney stone. It's completely different. You should not see what? Fever. Did you see how it is there? And if they give you select or apply for nephrolithiasis, if I give you and I put fever of 103, you should not pick it. They should not have fever. Same thing. If I present it like that, you should not select kidney stone as your diagnosis because there's no hiatus. It's thiasis. Thiasis means stone. Hiatus means infection. I play with words, you know, I'm not from America, you know, I'm a foreign guy, but I learned words, and that's what helped me in medical school. I learned words, and you use words, and science is all words. You look at it, and then they break the words, and you can figure out, even if you don't know what they're talking about, look at the word, break it into pieces, and you say nephro, kidney, light, what? Lithiasis, forming stone, kidney stone, pyelo, is infection. Every time they talk about pyelo, they're talking about infection. And nephritis is kidney infection. It's different. Now, if they tell you the individual has just pain here, this is your pelvic. So if you have pain, it's on top of the pelvis. What is something on top? What is the word for top? What do you guys think? What is the word for top? Something top is what? Supra. And this is the pelvis. What is the name of the scientific word for the pelvis when we describe it? It's pubic. So if I say you have suprapubic tenderness, that's all. It does not go anywhere. Suprapubic tenderness, that is cystitis. It's bladder infection, cystitis. Please don't confuse this with that or that. This is a free question, free 6 case study. If they give it to you, cystitis, bladder infection, pyelonephritis, kidney infection, nephrolithiasis, stone. The stone can block anywhere. It can start from here, here, here. So it changes depending on how long the blockage has happened. Nephrolithiasis, kidney stone may have infection, but trust me, they're not going to do that to you. They're not going to give you a kidney stone patient who have infection unless they tell you the blockage has been going on for a long time. In that case, they will give you ultrasound and they will tell you there is what? Dilation of the ureter. That is the key words. The ureter is going to dilate. And when you see that, yeah, that means there's 2 blockage and it's been going on for a long time. Okay, so this is my message for you. Acute GI problem should not be something you should worry about. If you need content on GI, check out NCLEX. There's a bunch of playlists